In this patient, ibrutinib could have technically been started earlier. Its current label is after a prior therapy with rituximab with an anti-CD20 containing regimen, and so this patient received it in a third-line setting. Technically, if he could have received this drug in a second-line setting and had received it earlier. Right now, there's no real good data that it would be that effective or more effective over chemoimmunotherapy approach as a frontline data. There's no indication for that, but this patient may have received it slightly earlier. Whether or not you do that, I think, again, comes down to the disease characteristics. If you've had prolonged remissions, you're likely to get really deep responses. Even in second-line settings with bendamustine, the response rates are known to be higher in bendamustine and obinutuzumab. They seem to be maybe more durable, but these are not head-to-head. When I'm thinking about going to targeted agents, I really want to know that the disease is kind of refractory to chemotherapy. Because these drugs still are effective and they can be used to gain deep remissions and durable remissions. And so those factors, the biology of the disease, and obviously sometimes these marginal zone lymphomas will transform into a diffuse large B-cell lymphoma, at which point ibrutinib is not going to be the one that can manage that. And if there's any clinical concern that at that second progression, there is a potential for transformation. More aggressive regimens such as this patient had R-CHOP are kind of the treatment of choice if there's any type of clinical concern. I think with marginal zone lymphoma, we're really looking forward to the future of these targeted agents and even potential immunotherapies as they start to come around. I think what's going to be important in the future are going to be learning how to use these monotherapies that we're currently employing and learning how they can combine with each other and the safety and toxicity. So I hope to see in the future combination studies with PI3 kinase inhibitors and novel anti-CD20 antibodies and look into combinations of ibrutinib and Revlimid, and some of these studies are currently being done. And obviously, we have immunotherapies such as, PD-1 inhibitors, which have shown some effectiveness in diseases like follicular lymphoma. Obviously, doing large studies in marginal zone lymphoma will be difficult, but even bispecifics, CAR T cells, these things are potentially on the horizon and may be able to salvage some of these chemo-refractory patients. And so learning how to combine these targeted agents, learning how to employ when and where immunotherapy-based treatments and understanding their effectiveness in this specific disease entity will be important, and I think those studies are on the horizon and are, we look forward to the future there.